We all know consists of nerve decompression, end-to-end anastomosis, nerve grafting, and rehabilitative procedures. I won't be touching much on nerve decompression and nerve grafting, end-to-end anastomosis, because Professor Mario Sana is giving a lecture on facial nerve tumors and facial nerve grafting, and I believe he'll be covering all those in his talk. So this is a animated, the edited version which I'm giving. I'm not including all this which were already in my talk. Now, rehabilitative procedures basically consist of gold upper eyelid implant, facial hypoglossal anastomosis, and various sling procedures. Whenever a patient comes with a facial nerve palsy, one of our primary considerations is treatment or looking after the eye. Now, this is a doctor patient who had an acoustic neuroma removed from the right side in the United States about 30-35 years ago. This is the right-sided facial palsy. Notice the loss of light reflex on the right side as compared to the left side. This patient had a lateral tarsorrhaphy done over here and still managed to develop corneal ulcerations, keratitis, and so on and so forth. Eventually, she became blind. She does not have any vision on this eye, and this is a doctor patient. To prevent these sequelae, early treatment of the eye is of primary importance. So, since 1997, I have been doing these gold implants. When I was a resident, I was doing it for all my teachers in this hospital. And again, I've just continued on and on. I've been fortunate enough to get good number of patients of Dr. Murali also to be added on to the series. So this is the list that we had. I had a series of about 64 patients till the end of 2005. It's theoretical, so I won't really stress on this. Now, the effects on the eye were basically classified by me into minimal congestion with trace keratopathy, keratitis involving the inferior 1/4 of the cornea, keratitis involving the inferior 1/3 to half of cornea with or without superficial ulcerations, and hazy vision due to nebular macular formation. The nebular macula forms where the corneal ulcerations become quite deep. So even if the visual acuity is due to improve, it will not improve so much because this is a little dense sort of area. Now, conventionally in India, a lot of people do tarsorraphies. So tarsorraphy is one thing which we have been trying to dissuade people from doing and instead prefer the gold eyelid implant. And this is why we have been speaking on this gold eyelid implants since the last few years, and still a lot of people do not seem to be using this procedure as often as they could be using. That's primarily because I think people are not really putting in an effort to learn the procedure or do it, although it's a very simple procedure. Now, the disadvantage of tarsorraphy are that it is cosmetically disfiguring. It reduces the field of vision. Sometimes you have a person doing a medial or a lateral tarsorraphy. Either way, it decreases the field of vision, offers incomplete corneal protection, gives rise to trichiasis and sometimes even permanent adhesions. Gold upper eyelid implants was started by Smelly GD, Barclay Roberts, Perdiccas, Joe Barpi. Mind you, they were all plastic surgeons. It was started as early as 1966. Now, what is the principle of this? Normally, eye opening is by 3rd nerve, whereas eye closure is by 7th nerve, that is orbicularis oculi. So, whenever a patient's lid is paralyzed, he's unable to close the eye, obviously. Now, this is a reciprocal action. So, whenever the levator contracts, is the orbicularis which contracts. Levator contracts is the orbicularis which relaxes, and vice versa. So, it's a very reciprocal action. So, what we actually do in this procedure is, on the normal side, whenever the levator relaxes, the orbicularis contracts and the eye closes. Whereas on the opposite side, when the levator contracts, the weight of this implant over the eyelid combined with the effect of gravity helps to take the eyelid down. So it's a very simple procedure. We are making use of gravity when the levator relaxes. The commercially available implants in the United States, they are available from MedDev Corp. This is a photo taken from the internet, and they are difficult to procure and a little bit more expensive. Difficult to procure in the sense it's not very easily available, and if you tend to import it, you know the cost involved in importing these stuff. So in India, Dr. Murali designed this implant along with an ophthalmologist as early as 1996. And the gold implant presently used by us is designed as per individual needs. It can be made of desired weight up to micrograms. Now, the implants which are commercially available, the ones which I mentioned from MedDev Corp, they are available as sizing sets of 1.2, 1.4, 1.6, whereas ours can go on to even some milligrams like 1.73, 1.75 and so on and so forth. It is easily procured as it's made locally with a trusted goldsmith, and it's very economical. How do we go about measuring the weight of this implant? I'd request people to please tone down their mobile or put it on the vibration mode, please. Not only for my lecture, for all the other lectures as well. Okay, weight of the gold implant is measured preoperatively by taping the eye with a small piece of micropore or sellotape, and these are the weights that we are using in the chemistry lab very routinely. So keep adding weights and see the weight which helps to completely close the eye. That's the weight of the implant. Additionally, we tend to add 0.10 grams more. That is, if I measure 1.8 grams, I'd rather put 1.9 for the patient than 1.8. The slight overcorrection that we do, because this is a mildly inaccurate way of measuring the implant. Abroad, they actually stick the gold implants on the lid of the patient, put a tape there, and that's how they measure the weight of the implant. And again, as I mentioned to you, they have 1.2, 1.4, 1.6. So they tend to overcorrect themselves. So in our series, we have found that a lot of patients have fallen into this category of 1.6 to 1.8. Usually, I would go to say that the mean is 1.8 grams. That's thereabouts what the patient requires to close the eye. So plus or minus a few grams on this side. Now, the implant itself is made of 24 karat gold. So this is the medial end and that's the lateral end. The medial end is made slightly broader than the lateral end because in our early series we found out that a greater amount of weight is required to close the medial end than the lateral end. Again, this length measures 2/3 the length of the upper eyelid. If you take the measurement from the medial canthus to the lateral canthus and take 2/3 of that, that's the length of this. So you measure the length. The breadth is about 5 millimeters on the medial end, 4 millimeters on the lateral end in an adult, and you can progressively decrease it as the age decreases. And of course, we use the flexometallic strips which we put on the eye and then take a curvature or a drawing of that curvature, hand that over to the goldsmith. That's how they give the curvature. Once you have the weight, you have the length and the breadth, the thickness determines itself. The most important aspect of this is that it must be 24 karat gold. A 22 karat gold would extrude. Okay, so make sure that whenever you tell the goldsmith, you must make it sure that it's 24 karat gold. Again, 24 karat gold is little malleable. If you think it's not fitting exactly to the contour, you can actually tend to mildly change the curvature with the help of your hand itself. It's provided with 3 holes in the center for fixation to the tarsal plate. The edges of the implant are to be made smooth so that it does not really poke the patient's eye. And more importantly, it's to be autoclaved. So once it's autoclaved, it becomes totally sterile. So all these inhibitions about preparing it with a local goldsmith are all unfounded. Now, the instruments used for this implant are very simple. They are the routine ophthalmic instruments. You use an insulin syringe to infiltrate the local anesthetic. That's what we call a corneal guard. Of course, the scalpel, the vernier caliper. The vernier caliper over here, which measures the distance of the incision site from the lid margin. That's the routine ophthalmic forceps, scissors and needle holder, and of course 6-0-ethylone to fix the implant to the tarsal plate. That's the way the procedure started. It's done under local anesthesia obviously, and you tend to put this corneal guard over here. We have stopped putting this cotton over here because it tends to abrade the cornea. So we have stopped doing this. We only put this corneal guard, stitch the lid margins to this corneal guard. The incision is measured 6 millimeters from the lid margin involving the middle 2/3 of the upper lid. This incision is then infiltrated with xylocaine with adrenaline. That's 1 in 200,000. You hardly need to use about 1 to 2 cc for this procedure. The incision is taken down involving the skin and the orbicularis oculi. So a pocket is created. You have skin, orbicularis oculi, and that's the tarsal plate over there. You need to create a pocket between the orbicularis oculi and the tarsal plate for placement of this implant. This pocket tends to go more medially and laterally than the incision site. That's the implant which has been placed in the pocket. You can clearly make out the skin over there, the orbicularis oculi muscle, and that's the gold implant placed over the tarsal plate. Now this implant is then sutured to the partial thickness of the tarsal plate with the help of 6-0-ethylone. The orbicularis oculi is sutured with 3-0-vicryl and the skin with the same 3-0-vicryl, or you can use an ethylone for the same. So it's a 2-layer suturing. This is the preoperative picture of the patient showing lack of Bell's phenomenon on this side, and that's the immediate post-op result. To show you the same thing on a dynamic motion, this is the patient you can see with the left side of facial palsy. You can see that the cornea is exposed. And that's the immediate post-op results. So on this side is the normal eye closure, on this side is the weight of the implant which takes the eyelid down. And we use gold because it cosmetically blends with the eye. So you can hardly make out a small bulge under the eye, but color-wise it is very good. And you can see that functionally also it's beautiful. Now this is yet another patient. This is the facial palsy side, and notice his eye closure. So in short, it does give you functional and cosmetic results, and hence it's a very widely accepted procedure. Now in some cases like this, you see a pronounced lower lid lag. In this case, they added a greater weight of the implant to close this eyelid down. This is not exactly right. Why I have put this slide is because this was a patient of a CA maxilla. A maxillectomy was done. There was a tumor left behind on the infraorbital margin. This patient underwent radiotherapy. In spite of that, we were suspecting, or rather the oncologist was suspecting that yes, there may be a little remnant tumor there. So I did not want to do any lower lid tightening procedure on this patient. In fact, we overcorrected the upper eye. And in hindsight, it was a good thing because this patient got a recurrence of the carcinoma which went towards the eyeball and ultimately had to do an orbital exentration. So this was a compromised condition, but usually when you have a lower lid lag, you'd go out and correct it. So there are various procedures designed. Now look at this patient who had a facial palsy for very long. Again, you can see a pronounced lower lid lag. So in these patients, it's necessary to do some sort of lid canthopexy, either a medial or a lateral canthopexy or a lid shortening procedure, and that's precisely what we did for this patient. The congestion on the eye is primarily because of the xylocaine with adrenaline which we used to put in the early days. Again, the results were tabulated this way. There was excellent resolution of exposure keratitis and healing of superficial corneal ulcerations. There was very good improvement in the visual acuity. 2 cases earlier had nebula and macular formation, so we couldn't really help the vision, but of course the watering and the redness stopped, and there was extrusion in these 2 cases. Now these extrusions were actually a technical mistake. I went about searching for the cause, as usual, went to the goldsmiths, found out whether it's 22 carat and etc. But retrospectively thinking, it was because one patient I had not really anchored it well to the tarsal plate, and in the second patient, it was a frail old patient, and in that the orbicularis oculi was very thin. So the implant had actually come into contact with the skin margin, and that's how it had extruded in the second case. So apart from those 2 cases, it has never extruded in our case, nor had we had any complications like astigmatism, which is sometimes reported in literature. But once those are corrected, then you tend to have very good results with this procedure. So in conclusion, the field of vision is not at all restricted. The functional result is very good. It's cosmetically excellent. It's an OPD procedure. It takes about 20 minutes. In fact, we were trying to show you a gold implant patient who's now waiting in the OT. But if Professor Mario is going to go to the OT first, then we may postpone the case, or we may not show you that case since I've already spoken on it. If possible, we'll definitely make it a point to show you this case. It gives immediate post-op results. So if you see a patient whom we have operated, of course there'll be a little bit lack of lid motion immediately post-op because of the effect of the local. But once the effect of the local wears off, you get to see the wonderful results. It can be used either as a temporary or permanent procedure. Now sometimes we do nerve graftings where we expect recovery, or facial hypoglossal where we expect recovery of these patients. So in those cases, we can use it temporarily, or sometimes even in Bell's palsy where patient has pronounced eye symptoms and you know that Bell's palsy is going to improve, or say the conservative line of treatment is not helping, then you can put this and take it out once the lid function improves, and it is very cost effective. If even you consider the cost of gold today, which is at a very high rate, the implant itself costs just about 2,000 rupees including the making charges. So that's pretty much effective for the patient, and considering it's a procedure under local anesthesia, it's after all your surgeon's cost which matters. So it's very cost effective as well. Coming to facial hypoglossal anastomosis, which we do for the face, the indications are when the proximal stump is too close to the brainstem. So it's very difficult to do a nerve grafting, failure of a facial nerve repair, or facial nerve palsy of more than 1 year duration. Now, if you have a facial palsy patient of less than 1 year duration, you would prefer to do a nerve grafting technique. Judicially, in a younger patient, nerve grafting can be done even up to 1.5 years or even up to 2 years, provided the facial muscle tone is maintained. But nerve grafting has worldwide been accepted that the best time to do a nerve grafting is within 1 month. And up to a 1 year's time, they have found reasonable limits of recovery. But after 1 year, they say that the recovery gets little down. So we tend to do after 1 year facial hypoglossal. But you get reports from Professor Fish, which says that he has done on a 1.5 year also, later he's done nerve grafting. That's how I say that you need to have a good tone of the facial muscles, or a younger patient whom the nerve takes a longer time to degenerate, so that you can utilize nerve grafting. The contraindications to this procedure are a type 2 neurofibromatosis where you expect multiple cranial nerve palsies, a 10th nerve palsy because that will cause difficulty in swallowing, beyond 3 years after injury when the facial muscles become atrophic, and then you have to consider muscle transfers like a temporal muscle sling, and that's exactly what I mean by loss of tone of facial muscles. So this is a movie. The incision extends from anterior to the attachment of the anterior helix, descends down anterior to the tragus, takes a soft turn behind the lobule of the pinna, and continues onto the neck along the anterior border of sternocleidomastoid towards the greater column of the hyoid bone. The tail of the carotid is mobilized and the anterior border of the sternocleidomastoid retracted to expose the posterior belly of digastric. The digastric muscle followed superiorly towards the mastoid grip leads to the facial nerve. As seen in this picture, you can see the exit of the facial nerve at the stylomastoid foramen. Other landmarks to identify the facial nerve are the tragus pointer, the nerve lying about 1 centimeter deeper to it, and the tympanomastoid suture line, the nerve again lying about 6 to 8 millimeters deeper to it. Alternatively, the nerve can be traced backwards from one of the peripheral branches towards the main trunk. The hypoglossal nerve is isolated as it courses between the jugular vein and the carotid on the undersurface of the digastric muscle. That's the hypoglossal nerve over there. The hypoglossal nerve with the descendens hypoglossae is seen in the lower part of the frame, whereas the facial nerve is exposed in the upper part of the frame. That's the descendens hypoglossal over there. That's showing you the hypoglossal nerve once again. The hypoglossal nerve is then sectioned cleanly close to its attachment to the tongue muscles, so that a maximum length of the nerve can be used for transposition to the facial nerve. Similarly, now the descendens hypoglossae is cut. The nerve is then rotated superiorly to approximate it to the facial nerve. This is a Jueller forceps which hardly causes any pressure on the nerve. It's the neuroraphy forceps instruments. The facial nerve is also transected close to its exit from the stylomastoid foramen area. That's to gain the maximum length of the facial nerve and maximum length of the hypoglossal nerve for anastomosis. Soft tissue overlying the facial nerve is then cleared. Care is taken to see that the end of the facial nerve which has been transected is a clean cut. The nerve end should never be crushed. It should be clean cut. The facial and the hypoglossal nerve are now being approximated, and you can see that the hypoglossal nerve is placed without tension. We are now switching to the microscopic picture. As you can see, to the left, you can see the facial nerve, and to the right, you can see the hypoglossal nerve. I'm trying to show you the clean-cut ends of the nerve. These nerve ends are then sutured together with monofilament 80. The suture runs through the epineurium of the nerve. Utmost care should be taken to see that the nerve bundles are not damaged. This movie is deliberately showed a little bit in detail because people do like to see this part of the nerve suture. The suture is now being passed through the lower end of the facial nerve. As you can see, this is the sutured nerve. We have taken a total of 3 sutures around the nerve, and you can see the nerves are very well approximated to each other. This is again an external photographic frame which is showing you the site of anastomosis of the facial and the hypoglossal nerves. That's the hypoglossal and that's the facial. That's once again the anastomotic site. Okay, the same principles of nerve suturing that we apply, I'd just like to touch on it in a very short way. One is suturing should be through the epineurium, and again the nerve must be approximated to the opposing surfaces very well. If the nerve is not opposing exactly, then you tend to get poorer results. Again, we tend to use monofilament 80, 90, 10, which is a little difficult to see. Keep the threads short, and you require a good assistant for this to really tie it up properly, else things can get a little messy for you. And again, if you think that yes, in the temporal bone you want to suture a nerve, you can use a glue, whereas on the periphery, for example the parotid area where it's moving, a glue is not used. You need to suture the nerve over here. So keeping all these factors in mind, you can do this facial hypoglossal anastomosis. That's again trying to show you the pre-op and post-op pictures. The same girl, that's her pre-op picture, left-sided facial palsy. We did an upper eyelid implant for her, as you can see on this side. This is a 10 months post-op picture. You can see very good eye closure, and of course she'll show you the facial movements. The nasolabial fold is the first one to recover, and she'll just demonstrate the movements of the face to you. The forehead is usually the last to recover. So if you have 10 months post-op picture like this, you do expect the patient to improve further and further more. Now again, facial nerve recovery can take place up to 2 years. This is a case where we showed you a total facial hypoglossal anastomosis, where you tend to explain to the patients that yes, you are going to have hypoglossal palsy, which tends to push your patient's tongue to the side of the palsy. Again, this is another patient where you can see again loss of the papilla of the tongue. So this needs to be explained to the patient. However, now with improvements in technique, we do not tend to do a complete facial hypoglossal anastomosis. This is done with a 1/3 thickness in 2001.
My eyes were not closing at all on the right side. The eye on the right side was very open with a result. I was feeling absolutely restless. And after the surgery, for the loading of the eye, and I could close the eye properly.
Okay, this is a doctor patient who had an acoustic neuroma removed on the right side, and you can see we have purposely taken an interview of a doctor because she knows both sides of the story as a doctor herself and as a patient. So she gives us a very good insight as to what the procedure can give. And this is actually just 1/3 thickness of the hypoglossal nerve, and of course we did the gold upper eyelid implant as you saw. So more recently we have tried end to side anastomosis. You can see here the facial nerve over here, which is anastomosed to side on to the hypoglossal nerve. But this, if you're trying end to side anastomosis, sometimes can get real tight. This length is not enough to sometimes reach the hypoglossal nerve. So this is not really the ideal way to do things unless it's coming without tension. In this case, we managed to successfully do it, and we had anchored the facial nerve to the parotid tissues over here. But otherwise, more recently, we have even started doing jump grafts. This is the facial nerve, lower and upper division. That's the facial nerve. That's the anastomosis there with the facial nerve. This is the greater auricular nerve graft. And of course, that's the hypoglossal nerve over there. Now, this graft is anastomosed here to 1/3 thickness again of the hypoglossal nerve, as Professor Kartush, whom I had been to United States, says, or it's written even in Mark May's book. To judge how deep your incision goes on the hypoglossal nerve, you tend to take a small 8090 monofilament and pass it initially through 1/3 thickness of the nerve, and then cut the hypoglossal nerve from here up to the level of the suture. Otherwise, once you cut the nerve, you're not really sure whether you've cut 1/3 or half or 2/3, So that's one way to judge how much you've cut, and you can exactly oppose this to the hypoglossal nerve. So there are various things in different ways of doing the same thing. What works well in your hands is good for the patient. And again, temporalis muscle sling is the last part of this lecture. I'll make it quick. Indications are facial palsy of more than 3 years duration, where the facial muscles become atrophic, failure of nerve anastomosis performed earlier. Of course, the contraindications would be an atrophic temporalis muscle as in an edentulous patient, temporalis muscle involved as part of any other sling surgical procedure, like cancers. Dynamic and static slings, I'm sure everyone is aware of that. And what we have done is temporalis muscle sling. This is just the surgery in 1.5 to 2 minutes. That's the incision site, like a hockey-shaped incision. Expose the temporal muscle, just as you would have along with the fascia. That's the entire fascia intact over the temporal muscle. Then create subcutaneous tunnels from here going down, one to the nasolabial fold and one to the lower lip. That's gone there. And we have taken an incision there. So that's one, and this is the second area where you need to do it. Earlier, they used to do a temporalis muscle sling for the entire face, that is including the upper and lower eyelids. But now, with the gold implant, we tend to do that for the upper lid, and of course, the sling in required cases for the lower lid, for the lower face. So that's the temporal muscle which has been taken along with the fascia. Now, this temporal muscle is not going to be enough to reach the angle of the mouth, because additionally you have a zygomatic process over which the temporal muscle has to be rotated. In some instances, you can even excise the zygomatic arch and then rotate it. Even then, if your muscle falls short, you can actually suture the fascia to the muscle on this edge and then lift the fascia off the temporal muscle as shown here. This is the edge of junction of the muscle and the fascia, and strips are made of this muscle and fascia. 2 strips are made. You can take the central third of the temporal muscle. This needs to be sutured again. That's the strips which we have shown you. And then these strips are transposed, one to the nasolabial fold and that to the other, and are sutured to the muscles in that area. Always this muscle will appear short, but you need to take care that temporalis muscle sling, the patient's face is always to be overcorrected. You tend to lose some amount of, you see this face, it's been overcorrected. That's because you always tend to lose some amount of tone and mass of the temporal muscle initially, and that can really put your face back to where it started from. So when you overcorrect, it tends to remain. The face looks good at rest, but whenever the patient is chewing or whenever the patient exhibits emotions, obviously this is going to be a asymmetry on both sides of the face. But yes, it does give patient some amount of motion on this side. This is the bulge on the temporal area because it has been transposed over the zygomatic arch. You can also see that she's had an upper eyelid implant. Okay, so that's her pre-op picture, the same patient whom I showed you earlier with a pronounced lower lid lag, and that's her post-op result. This is yet another series. rather one patient which I kept here. Again, accessory procedures can also be done. Now, suppose a patient, you've tried all this and still some amount of defect is seen. There are accessory procedures which are primarily done by the plastic surgeons. Facelift, brow lift, muscle shortenings, and ancillary cosmetics. Like for a lady, to obscure the loss of the, furrows, you can have the change in the hairstyle, or for a man, you can have a growing of a mustache, which tends to decrease the defects seen as of the nasolabial area. Again, in conclusion, first of all, you need to prevent injury. You need to give early and appropriate intervention. We as ENT surgeons need to be well versed with all the procedures, including reanimations, because we all believe that facial nerve right from the brainstem to the periphery falls into the domain of the ENT surgeon. We are primarily responsible, and with the growing advances, we need to be sure about where we do grafting, where we do hypoglossal facial, and we can do a great help to even neurosurgeons who can provide us with these cases. And we should endeavor to offer improved functional and cosmetic results in all patients of